Good morning. The topic for today's class is necrosis and gangrene. I'll be covering the topic under the contents of introduction, necrosis, gangrene, clinical implications in endodontics, which include pulpal necrosis and gingival necrosis, the effects of various materials used in dentistry on the gingiva and alveolar bone, which include calcium hydroxide, sodium hypochlorite, pulp debiotizer, chloroform. We'll be discussing a few case reports and a short summary of the class. Necrosis is defined as total death and autolysis of a tissue. It is invariably accompanied by inflammatory reaction. Necrosis can occur due to microbial agents, hypoxia, chemical and physical agents, or due to immunological injury. Two essential changes that occur in necrosis because of irreversible cell injury are cell digestion by lytic enzymes and devegetation of growths. Coming to the pathogenesis of necrosis, there are two broad pathways in which necrosis may occur in an organism. The first pathway, oncosis, where swelling of the cells occur. The cells then proceed to blebbing, and this is followed by pignosis, in which nuclear shrinkage transpires. In the final step of this pathway, the nucleus is dissolved into the cytoplasm, which is referred to as karyolysis. The second pathway, there is a secondary form of necrosis that is shown to occur after apoptosis and budding. Cellular changes of necrosis occur in this secondary form of apoptosis, where the nucleus breaks into fragments, which is known as karyohexis. Coming to the different types of necrosis, these include coagulative necrosis, liquefaction necrosis, caseous necrosis, fat necrosis, and fibrinoid necrosis. The first type of necrosis, as we discussed, is coagulative necrosis. It is the most common type of necrosis caused by irreversible focal injury. It occurs mostly by sudden cessation of blood flow and less often from bacterial and physical agents. The organs which are commonly affected by coagulative necrosis are the heart, kidney, and the spleen. Second type of necrosis is liquefaction necrosis. It occurs commonly due to ischemic injury and bacterial or fungal infections. It occurs due to degradation of the tissues by the action of powerful hydrolytic enzyme. The common examples of liquefaction necrosis are gangrene and abscess cavity. Caseous necrosis is a distinctive form of necrosis encountered most often from tuberculosis infection. Its pathology combines features of both coagulative as well as liquefacting necrosis. This is the case of caseous necrosis, which is shown in the image below, with confluent cheesy tan granulomas in the upper portion of the lung in a patient with tuberculosis. Fat necrosis is a special form of cell death which occurs at anatomically different locations but morphologically similar lesions. It has different types, which says such as acute pancreatic necrosis and traumatic fat necrosis. Fat necrosis is hydrolysis of total fat present in the adipose cells in glycerols and free fatty acids. The damaged adipose cells assume a cloudy appearance. The leaked out free fatty acids complex with calcium to form calcium source, which is known as saponification. Fibrinoid necrosis or fibrinoid degeneration is characterized by deposition of fibrin-like material which has staining properties of fibrin. Its examples include immunological tissue injury, arterioles in hypertension, and peptic ulcer. Coming to the necrosis of the oral cavity, cancrum oris or noma is a rapidly spreading mutilating gangrenous stomatitis caused by normal oral flora that becomes pathogenic during periods of compromised dentition. A recent debilitating disease or illness usually precedes noma. It is chiefly seen in children, but also reported in adults under certain conditions like malnourishment. This is a case report showing a case of cancrum oris. Coming to the clinical implications in endodontics, pulp necrosis is complete or partial death of the dental pulp. This could be due to persisting inflammation of the pulp tissue. It can be caused either due to bacteria, trauma, chemical irritation, or by the effect of external beam of radiation therapy. The pulp as a rich neurovascular supply that promotes the effects of inflammation and may lead to rapid degeneration and necrosis. The basic reaction tend to protect the pulp against caries, which include a decrease in the dental permeability as well as the formation of tertiary dentist. Necrosis, although secondary to inflammation, can also occur following traumatic injury in which pulp is destroyed before an inflammatory component, leading to gangrenous necrosis of the pulp. As the inflammation progresses, the tissues continue to disintegrate in the center to form an increasing region of liquefaction necrosis. Because of the lack of collateral circulation and the unyielding walls of the dentine, there is insufficient drainage of the inflammatory fluid. This results in localized increase in the tissue pressures, causing the destruction to progress unchecked until the entire pulp is necrotic. In short, decreased blood supply causes an infarction, which leads to necrosis and ultimately the death of the pulp. The region of necrosis contains irritants from tissue destruction and microbes, both anaerobic and aerobic. These irritants contact peripheral vital tissues and continue to exert damage. Bacteria then penetrate to the boundaries of the necrosis but are not observed in the adjacent inflamed tissue. However, the toxins and enzymes are continuously permeating the surrounding tissues and initiate inflammation. Where liquefaction necrosis contacts dentine, the pre-dentine is lost, probably by the action of collagenase. Since this permits the bacteria to penetrate into the dental tubules, it is necessary to remove these dentine layers on all walls during canal extraction. Adjacent to the liquefaction necrosis is a zone of chronic inflammation. Coming to the symptoms of pulpal necrosis, necrotic pulp causes no painful symptoms. There may be discoloration of the tooth, which can be the first indication that the pulp is dead. The tooth lacks its usual brilliance, luster, and translucency. The presence of a necrotic pulp may be discovered only by chance because such a tooth is usually asymptomatic and the radiograph is non-diagnostic. Teeth with partial necrosis can respond to thermal changes owing to the presence of vital nerve fibers passing through the adjacent inflamed tissue. Foul odor can be observed when the pulp chamber is open. The necrotic pulp may become secondarily infected by putrefactive bacteria from caries. The diagnosis of pulp necrosis is usually not routine. Pain is absent in a tooth with total necrosis. Swelling, mobility, and response to percussion and palpation are negative, and there is no response to vitality tests. The radiograph generally show large cavity or filling and thickening of the perineum. Gingival necrosis, the death and degeneration of the cells and other structural elements of the gingiva. Interdental necrosis is a progressive disease that destroys the tissues of the papillae and creates interdental craters called interdental necrosis. Advanced interdental necrosis leads to a loss of periodontal ligament attachment. The effects of various materials used in endodontics on the gingiva and alveolar bone will be discussed in the next class.